Thank you. Amol, I really enjoyed your talk. And I think you are leading from the front as far as gallbladder cancers is concerned. I'd like to invite all the medical oncologists on the panel from various parts of the country and Dr. Milind Javle as well, who's kindly agreed to be here. And Amol, if you could be around as well, that will be great. Dr. Dipanjan Panda from Delhi. Dr. Ashish Joshi can't join in. He has excused himself. Dr. Neeti Raizada from Bangalore. Dr. Tanveer Maqsood from Surat. Dr. Boman Dhabar from Mumbai. Dr. Ravi Vategaonkar from Pune. Dr. Mehdi from New Delhi. Dr. Taran from Indore. And Dr. Sud from Bangalore. So it's a great pleasure. I have quite a few cases, but Amey, please tell me when we are running short of time, because I do understand you're running late. So we will wrap up whenever you want me to wrap up, actually. Just give us a 1 minute notice. So just moving on, I think what we are going to discuss are real world cases and how do I treat. So this first patient was we discussed actually in the molecular MDT that we have on Fridays, and Dr. Milind has kindly agreed to come for some of our patients, and he's, I think, one of our biggest supporters globally. So this 54-year-old gentleman, normal PS, comorbidities of diabetes, hypertension, had COVID in April, presented in April last year. Presented in July 2020 with abdominal pain, presented to one of the centers of excellence in India, in North India, was diagnosed with stage 4 unresectable gallbladder cancer, T3N2M1. So it was a left para-aortic and aortocaval. So, I mean, I would like to ask the panel, what at this time, how do you define the intent of therapy? Because I remember when I was in Tata Hospital, I would sit and, deliberate with Mahesh and Shailesh the whole time. And we'd say, and that's how the neoadjuvant GEMSIS data came about, that, why should we just relegate them as palliative alone? Why can't we do something and, treat neoadjuvantly? So what goes through your mind? I'll start with you, Milind. If this patient came to you, what would you define the conversation with the patient? How would you define the intent?
Sure. First of all, I'll just take a minute, Bhavana, to say I'm very proud of your pioneering work with the molecular tumor board. We've had it at MD Anderson and we quit. Nobody attended. And you've been doing it for such a long time with so much success. So, well, as you know, metastatic gallbladder cancer loves the sites of metastases besides nodes, the liver and peritoneum. The prognosis depends on the sites of metastasis. Great stage 4 metastatic gallbladder would be considered incurable. As Amol said, therapy would be palliative. However, these patients do have a little better prognosis, and we are looking for that N of 1, which is because it's important to that patient. So I would consider systemic chemo. I would do molecular profiling if we can get it, and then hopefully use chemo as a bridge to the next step. I don't think it's absolutely crazy to consider surgery down the road, although right now it would be crazy. Para-aortic is stage 4. Consider local ablative therapy, perhaps, radiation down the road. But currently it will be systemic, and hopefully we will understand the trajectory of the disease.
Yeah. Would you agree, Dipanjan, Amol?
Only one thing, I generally agree with Dr. Javle, but considering there is a high prevalence of chronic infectious disease in India, I generally, when I find there is only unresectability due to lymph nodes, I would like to assess those lymph nodes by their size, by their look, their SUV max, and if possible, FNAC with either endoscopic ultrasound or EBAS, depending on that. Because in sometimes, although rare, maybe in 5 to 10% cases, we do find that these nodes are actually inflammatory, and that makes them. And I am an optimist. So in these cases, although this is technically an unresectable and metastatic disease, but when we start the treatment, we sometimes see them doing exceptionally well. And in this case, especially the younger patient with good performance status, we sometimes give more aggressive therapy, like considering local ablative treatment or radiation. And sometimes I started using triplet therapy with nab-paclitaxel for these patients.
Yes, the GAP protocol, I think, which is really amazing and very well tolerated. So I agree with you, Dipanjan, about, I would say, when I was in Tata Hospital, almost 20% of these patients had tuberculosis, 20 to 30%, quite a huge number. And to label them as M1 is not right. So we move on. Sorry, I stopped screen sharing so I could see all of you. So this patient then had an MDT discussion. Now we come to the choice of regimen. I think, Dipanjan, you've already said you would prefer the GAP protocol. Milind has said NGS is something which we should do. And so as far as the protocol is concerned, would all of you prefer GemCis, nab-pacli, or any of you would go towards FOLFIRINOX? I'll just show the paper that Dr. Atul, the phase 2 study, has published, and I know there are some papers from China as well on modified FOLFIRINOX, which is making its way into gallbladder. Amol, please go ahead.
Before going for the regimen, the practice for the such kind of a disease, there was very nice work published from MAMC Delhi about the laparoscopic staging, and they showed that in such situation, 20 to 25% there will be surprises, peritoneal spread, and the unnecessary further therapy basically protocol can change. So I just, though I insist my surgeons always to consider such kind of a novel work, but it's always it's a large data. This is 550 patients and very nicely written article, but we never talk about it. In stomach cancer, we always talk about this laparoscopic staging along with the PET CT, but here in case of unresectable disease, we always forgot.
So I think that's a very good point, Amol. How many of us, if we just take a dual diagnostic laparoscopy, I'll start with Milind. Do you do it in all your GB patients like this?
So, I mean, I totally agree with Dipanjan. We should get a biopsy. We can. But, we don't see TB in the US. Generally, radiology and the pattern of spread, we don't always necessarily biopsy. PET, CA99, but there's nothing wrong in getting a biopsy. In terms of laparoscopic staging, not so much. I mean, as you know, there's always this fear with gallbladder, Amol, with this fungation through the surgical sites and so on. So we're very careful not to intervene unless we know that it's for cure. Because often patients undergo cholecystectomy and they come with this fungating thing through the skin. So we tend to avoid it. I want to make a point about the regimen, Bhawana. There was a Prodige group had a phase 3 trial of GemCis versus FOLFIRINOX in biliary cancer, which was basically a negative trial. So they stopped using FOLFIRINOX. So Amol, in India, you use GEMOX quite a lot. So maybe that is your experience and we should learn from it. Maybe FOLFIRINOX works in India. But in the West, we are doing away with it because that study was negative.
Mm-hmm. What about you, Dr. Mehdi? What would you do diagnostic lab, and what would be your choice of regimen?
My choice is chemotherapy regimen of choice is either GemCis or GEMOX. I am yet to start using 3-drug combination, and FOLFIRINOX I am not using much because of toxicity. Mm-hmm. And so far the laparoscopic staging is concerned, I am not, I think if radiologically possible, CT guided biopsy is possible, then I am suggesting that, but laparoscopic biopsy I am not suggesting.
So we are also not currently doing it, but Amol, that's a very good point. I mean, and it's Anil Agarwal, no?
Study. Yes. It's not about the biopsy. It is about the
staging. Yes.
And in that study, they didn't find any complications the way we are saying. I agree with Professor Milind sir about this, that there is a fungating we see. But the GB, 70% of the time it comes from the inferior surface. There is a peritoneal spread, and obviously it becomes upstaging. And that time,
you're probably right about that, but it depends on the quality of imaging, And
problem with the GB is such kind of patients are extremely rare in the clinic.
Dr. Patel, I would like to just make a comment, if Dr. Bhawana, if I may.
Yeah, sure, please.
See, recently our over dependence on PET CT has made some really complicated issue. You see, most of the PET in private has a lower quality CT, and peritoneal spread is not very well picked up in PET CT.
Yeah.
And both clinicians as well as the nuclear medicine people who report that PET CT, you'd be surprised to know most of the PET CT is actually reported by people in nuclear medicine and not radiologists. There are a few centers where there is a dual reporting, but in most of the smaller centers with PET, nuclear medicine people. So with all due respect to them, there is some issues. They are using less contrast, and there is a trend, Dr. Bhawana, many of the PET are non-contrast CT. So that really creates a problem with reporting of the peritoneal disease. I have seen if a properly used contrast enhanced CT scan with full IV as well as oral contrast is given, administered and reported by a qualified and experienced radiologist, peritoneal disease in gallbladder cancer can be picked up on a CT. So I think we need to reorient ourselves and tell our juniors that most probably contrast enhanced CT scan is a better thing to look for a peritoneal disease. Another issue with laparoscopy in private setup is that a laparoscopic biopsy costs as much as surgery. So what is feasible at LNJP being a government hospital, this issue of a laparoscopy assessment will increase the cost of treatment by 1 point for a surprise.
Thank you, Dipan. I would say to all panelists, please put your hand up because I'm looking at any raised hands as well if you have a comment. So moving on with the patient. So NGS, I think we already said we should do it and maybe we can discuss. Dr. Atul Sharma from AIMS published this study, phase 2, with an overall response rate of almost 40%. This is CR plus partial response, not stable disease in unresectable or metastatic gallbladder cancer. So this patient actually received 2 cycles of modified FOLFIRINOX, had poor tolerance, and then went on to GEMOX, went back to FOLFIRINOX. So ultimately completed about 6 cycles to an excellent partial response. And in December 2020, he underwent a laparotomy and open radical surgery, basically, which was R0 resection, YPT3N0. The nodes were all reactive, the aortocaval retroportal, and he received adjuvant GemCis 4 cycles. So we can discuss about the adjuvant treatment as well, but I want to get to the molecular bit. May 2000, about 3 months later, he presented with the loss of appetite, back pain, rising markers, rising bilirubin, constipation, nausea, vomiting. So he had multiple ERCPs between May and biopsies between May and December, and also stent changes for biliary decompression. The bilirubin would come down and come back up. And in December biopsy, I think they confirmed that the patient has an adenocarcinoma. So that this is the tissue NGS, which shows an ARID1A alteration and an NTRK alteration, CDKN2A TP53. This is the foundation report. This is the tissue NGS, and the blood NGS was also sent, which also showed this NTRK mutation. So basically, it's and the VAF is almost 49%. So this patient actually, we felt that had a good biology. The reason he came to us was because he was referred for proton therapy for just localized disease. There was no disease, metastatic disease anywhere. And we discussed in the molecular MDT and the our main MDT as well, and decided to go ahead with proton therapy and capecitabine, which he's currently undergoing now. So I'd love to have your thoughts on the NGS report. Dipanjan first, go ahead, and then Dr. Milan.
No, I just have a query. In one report, you say there is an NTRK alteration. In one report, you say there is an NTRK mutation.
Yeah.
I am correctly knowing that NTRK alteration, larotractine works, but not in NTRK mutation. Dr. Javle might correct me if I'm wrong. So there is some...
So dependent, I think they're saying the same thing. The alteration was basically the mutation, but it was not a fusion. So unfortunately, mutations are not actionable. NTRK mutation is, and larotractine and entrectinib don't work. And we don't know enough about mutations to know whether they have poor prognosis or good prognosis. So this is not actionable. ARID1A is one of the commonly mutated genes in gallbladder cancer. And there's controversy that some people say it's a DNA repair gene. As you know, Bhawana, you probably treat ovarian cancer. You see that quite not that uncommonly in ovarian.
No, I think breast and yeah.
Breast, okay.
But we have gynae experts here. Sudeep is here.
Gynae experts, yeah. And some data from Gordon Mills and other people, there's 2 papers from MD Anderson. They felt there is a benefit with olaparib and pembrolizumab, PD-1, in patients who have ARID1A mutation. It was in like Cancer Cell or something, kind of highly placed journals. So given now the data with durvalumab, I mean, one could consider some sort of immunotherapy as well. But you people know very well in this group in India that gallbladder cancer with jaundice is bad news. I mean, because it's, involving the extrahepatic biliary duct. And radiation is a good choice, will prevent obstruction. But I sort of disagree, Bhawana. I don't think the biology is good here. It's like 4 months after adjuvant therapy, right? You have recurrence.
Yes, yeah. But between May and December, there has been no metastatic disease. It's just finally we got some evidence that it is disease related before offering radiation therapy. We thought just it's a post-surgical stricture. So
that could be, yeah.
Yeah.
But I mean, if it's not a stricture, you prove on pathology. Generally, I find gallbladder cancer with jaundice just doing poorly.
Doesn't do well. Yeah, I agree with you there. And also, I think the foundation misses out on the fusions because it's a DNA-based test. That's the other point that came about.
They can miss, but they have a good algorithm. Yes, you do need RNA-seq. You do. Might be a benefit, but I think for practical purposes, it's enough. And NTRK fusions are such a unicorn; it's very rare.
Very rare. Okay. Have you had any biliary tract gallbladder cancer, maybe with NTRK fusion?
So I'll give you one example, which I would like you all to remember because I learned from that example. This patient came in with advanced biliary cancer. Her jaundice was 21. Bilirubin was 21. So obviously I thought no drug was approved. I said this patient should never get treated because, who can treat at 21? Mm-hmm. And we told the company actually allowed the patient on the trial at 21 to bilirubin to be treated. And this woman woke up from hospice. So with NTRK fusion, if they're on a ventilator, don't give up because it's the very rare situation where something actually works.
Wow. Dr. Bowman, do you have any comments? I see you've joined. Please unmute yourself.
What I saw that there were 2 trials presented in ESMO, STRAC trials.
Yes.
STRAC 1 and 2, and there they had mentioned that NTRK or TRK fusion or amplification. And if I'm not mistaken, it is an entrectinib drug which has worked better than the other one for GI malignancies. Mm-hmm. Am I right, Dr. Javle? Or?
You're right, Dr. It is a little better record.
A little better.
Numbers are very small.
Less than 1%. What I saw also.
Yeah.
Great. Dr. Taran, Dr. Sud, do you have any comments on this case? And then we'll move on to the next one.
Still waiting for any patient to have NTRK fusion.
Yeah. Yes. So I was really excited when I saw this report. Amol, go ahead.
Just a bit changing the track for, again, Professor Javle. Sir, the way you are treating with the such kind of Josh with the entrectinib, what's about your take on with the bilirubin 15 and giving gemcitabine?
So, well, we treat those. Yeah, well, that's a difficult question because, we do treat them if patients are waiting for transplant with high level angio, etc. But the original study with gemcitabine never went to a bilirubin of more than 5 or 7.
Yeah.
So we prefer FOLFOX. And there is oxaliplatin studies with very high levels of bilirubin. So we prefer FOLFOX. And I don't generally use,
With a passion with working in the gallbladder cancer.
Yeah.
And when I joined my institute, Army Hospital, R&R, so one of the patient received gemcitabine at bilirubin 25, though it was CS stomach, and
Yeah.
there's so magical responses we got and some modified doses. Then we reviewed the literature again, the gemcitabine, cisplatin. There is no much of contraindication with the deranged LFTs, but those trials are never looked at. But our ground problem is this: almost 30% patient will come with the bilirubin 7, 8. So we started a small project. So up to 15 bilirubin, we started giving the gemcitabine with the modified doses.
Sure.
They're tolerable.
And they tolerate it?
Already, yeah. There are 5 patients, but somehow I got moved out from that place and the COVID came, so the study halted. So my point is that if such kind of passion is there, certainly biliary tract is going to do much better.
We have to individualize, yeah. Dr. Neeti, you have any comments on this case? Dr. Neeti Raizada?
Yes, ma'am. With the Topaz 1 data, I think I would possibly want to use immunotherapy upfront in this case. And instead of doing diaglap, maybe do an interim assessment with a scan and see what happened to the lymph nodes. And then possibly go ahead.
I'll just call you back at 10 minutes.
Local therapy.
I will call back.
So you would give immunotherapy with GemCis?
I mean, if it is M1 disease, then yes, there is some data now, at least with Topaz 1, that we can extrapolate cholangio data to GB also and add durvalumab and continue with durval later on. But again, it is yet to come in the recommendation line. And about the GAP regimen, I mean, we have had patients in their 20s and 30s having gallbladder malignancy, being one of the most common in our country. And probably that is the setting where I would add a third drug rather than at 54. I mean, generally, I would use a 3-drug regimen in younger patients and more fitter patients with limited disease, not extensive disease.
Yeah, I think that's a good point. Yeah, very good point. So moving on to our second patient, second line options. Again, I just wanted to highlight this amazing study from Tata Hospital where they Kapiri versus irinotecan and actually showed that irinotecan is a very good option, irinotecan alone. So I won't delve much into it. We'll move on to a second patient and we'll whiz through it because I'm aware of the lack of time. 59-year-old patient, his father died of pancreatic cancer in 50s, has 3 daughters, presented with scapular, never saw anybody and did not have any genetic counseling or BRCA testing in those days. So presented with scapular pain, basically in April 2019 was diagnosed with extensive liver metastasis and metastatic adenocarcinoma pancreas. Dr. Bowman, I think we've treated this patient together. Tissue was not available for somatic mutation testing, normal PS, raised liver enzymes, normal bilirubin. He was started on modified FOLFIRINOX, had a partial response to 6 cycles, and the plan was to give him 12 doses and put him. So the germline testing, I mean, the question is, we'll come to it, whether you would do it in diagnosis in all patients in early pancreatic cancer as well, or would you do it at progression and the somatic NGS when you would do it? Basically, the MyRisk showed in this patient that he had a BRCA1 mutation, completed 11 cycles of FOLFIRINOX and then progressed within the liver and pancreas, and then started second-line GemNAP paclitaxel. I mean, his liver was extensive liver metastasis, and also he kept on developing sepsis and liver dysfunction on his. So the germline testing, when would you do it, and what is the window of opportunity to start olaparib? Because here, 11th cycle he started progressing, and I think we were treating him. Dr. Bowman was there, me was there. We were in touch with Dr. O'Reilly at Sloan Kettering as well. And the plan was to start him on olaparib maintenance after 12 cycles. Whether we should have started sooner, whether we lost the window of opportunity to start it, what does everyone do? Dr. Milind, what would you do? And then I'll go on to everyone else.
So, now the NCCN guideline is to do germline testing on everybody because we have so few actionable alterations. We had a very nice talk earlier with pancreas. But honestly, yes. I don't believe 25% have actionable mutations. There's much smaller.
Yeah.
But, I mean, the Polo trial allowed after 4 months of chemo, you could go on. But, you treated FOLFIRINOX. That is like the grandfather of olaparib. So
yeah,
I don't know that the patient would have not got refractory to olaparib as well. I mean, I think BRCA2 does better than BRCA1. even in the polo. And this patient got optimal therapy.
Yes, absolutely. Dr. Bowman?
Yeah, the NCCN guidelines and up to date what says 16 weeks, and the patient should not have disease progression or a stable disease or response. Then we should be starting olaparib.
Yeah.
If it was that. And I think so. Somatic mutation also should be done upfront if possible.
Yes.
I don't know. Yeah. Then you can decide whether to use platinum or not. Not that it's going to make
Yes,
difference.
I think this patient had somatic and germline both done, at the beginning. But the problem with this patient was the tumor was very necrotic. So they could not find any DNA. All the biopsies were always negative. There was always an element of infection, necrosis. I think it was a very fast dividing tumor.
So liquid biopsy, do you do that often?
We did that in this patient, liquid biopsy. Yeah. So, and that showed a lot of BRCA alterations, and the thinking was there's probably BRCA reversion. And you are right, he probably would not have responded to olaparib. That was the thinking. And Dr. Taran, please go ahead.
Sorry, ma'am, to bother. There are three things which are there in my mind. As Dr. Javle sir has said, ki FOLFIRINOX is grandfather of olaparib.
Yeah.
I could not get it. What does that mean? Second thing, जैसे BRCA में platinum sensitivity was there in initial days when we used to learn BRCA in breast cancer or ovarian cancer. We used to listen that cisplatin is a good worker in BRCA positives. And what about the patients who are heterozygous or of unknown significance BRCA?
What do you,
Dr. Javle sir?
Yeah, so Rakesh, I mean, I was just being facetious, the grandfather of olaparib. Actually, GemCis, Eileen had a good study with GemCis in JCO with BRCA. That's a very good regimen, medium survival of 15 months with GemCis for BRCA patients. So they perhaps don't need FOLFIRINOX. They're very sensitive to just GemCis. And then the goal of olaparib is really preserving quality of life versus continuing, FOLFIRINOX forever. So I also want to mention, I don't, please don't take it as that I'm trying to blow the trumpet of my group, but we had a paper in JAMA Oncology for non-BRCA DNA aberrations in pancreas cancer, with ATM being the most common. And for them, olaparib works as well. So I would generally use platinum for anybody with the DNA repair alteration. And switching to olaparib is a good idea just because it gives some chemo-free interval. Take a pill twice a day.
Yeah, so we have a third patient with ATM mutated pancreatic cancer. We may not have time. So would you recommend giving olaparib in ATM mutated? Yes? Yeah. Okay.
I mean, as you know, Bhawana, the new generation ATR inhibitors work better. But
yes, absolutely.
Not that approved or not available. So olaparib works. That in that JAMA paper, most of our patients had ATM mutation and they didn't have responses, but they had prolonged stable disease.
Okay, great. Dipanjan, go ahead.
My question was for any non-BRCA repair mechanism deficiency disease, should we be considering olaparib maintenance after say 4 to 6 cycles of platinum-contained chemotherapy?
I think so. I think just give it a thought, Dipanjan, because as long as they are platinum sensitive, if they are platinum refractory and you give them olaparib, it's not going to work. But if it's really a DNA repair alteration, like PALB2, ATM, I think it makes sense. I would like to get a pill, not FOLFIRINOX.
Yeah, I think it's good, and maybe collect some real world evidence as well. Yeah. And on these patients. Dr. Mehdi, you want to say something?
Yeah, my question is, since rucaparib is available at lower cost, is it, can we use rucaparib in place of olaparib in BRCA mutated patient?
It is not lower cost at all. It's actually the generic is as expensive as olaparib. That's my thinking. I mean, am I right? Please, someone educate.
No. Rucaparib is much cheaper. I'll tell you, it turns out around 50,000-60,000 per month.
Okay.
And is an approved treatment for pancreatic malignancy. So olaparib and rucaparib both are approved, if I'm not mistaken.
Yes.
Yeah. Okay, I thought it's the same cost. Dr. Vishwanath, you had your hand up. Go ahead.
My question was very similar to the previous speaker. So regarding rucaparib and with the expansion of including the somatic BRCA as well in the rucaparib study, I know it's a phase 2 study. I would like to have Dr. Javle's thoughts on that.
So Vishwanath, I think rucaparib is reasonable to use. I agree with you. But that study, if you read the report, they reported as mostly a negative study, that it didn't reach the value for further expansion in pancreas. So it's not, at least for us, improved indication for, but I'm with Dr. Bhawana. It's probably not so, it's probably reasonable. But the company itself decided not to develop it in pancreas anymore.
Sure. Thank you.
Yeah.
We have a generic version available here in India, so I think we can do it.
Well,
yeah.
Then there's no question. Rucaparib.
Yes. No, I'm going to try it as well. I thought the last I checked a year ago, the cost was the same. Dipanjan, you have your hand up. Any comments before we move?
No, ma'am. I think that was the previous one.
Okay. Amey, do we have more time, or shall I move on to the third patient, or what do you?
Yes, ma'am. We have time for 6 to 7 minutes.
Okay, great. So we did the ctDNA in this patient, and as you can see, there were quite a few BRCA alterations, and there was I think low frequency of BRCA mutations. So there was this question of BRCA reversion. So I think we've already discussed this. Coming on to a third patient, 62-year-old lady with normal PS, presented with abdominal pain, basically was diagnosed with pancreatic cancer, CT2NX-M0 adenocarcinoma. Her family history, mother had leukemia. She herself was actually treated for carcinoma ovary in 2002 with Paclitaxel 6 cycles followed by optimal debulking. So basically, she was taken up for surgery in one of the centers of excellence in North India, and at that time was found to have nodules in the liver. The surgery was abandoned. The MRI liver was done, which showed multiple liver metastasis, normal end organ function. That's when she came to me. We sent germline testing, which showed this ATM mutation. She was referred for genetic counseling. We started her on FOLFIRINOX. She had a good partial response to it. And we switched to FOLFIRI due to grade 2 peripheral neuropathy. And she stopped this in September 2019 due to grade 2 tiredness. We decided to give her a drug holiday. She presented a few months later with abdominal pain, rise in CA19-9. The PET scan and the PET MRI showed an ongoing response in the liver, but the pancreatic mass had increased by 1 centimeter. So, and because she was symptomatic, we decided to give SBRT to the pancreatic mass. And after that, she was observed. She was very keen not to have any sort of treatment at all. Presented 5 months later, again with, every time she's presented with abdominal pain, rise in CA19-9, liver enzymes, and then showed extensive liver metastasis. She declined biopsy, but agreed for a ctDNA test, which also showed a high VAF ATM mutation and a low level of FGFR1 amplification and KRAS G12D mutation. So I think ATM, you've already educated us, Milind, about this. But my question is local therapy in HPV cancers. So if you would consider, and I would love to know the thoughts of the panel as well, because I think I've discussed 3 patients where we have somehow, like for this patient, she had a very good quality of life after SBRT. So do you have any criteria where in M1 disease patients you would consider, I would say all HPV cancers, local therapy?
Definitely. I think, as you know, we don't have anything great to offer, unfortunately, Bhawana, in medical chemotherapy alone.
Yeah.
The treatment of these cancers should be multidisciplinary. So patients who have relatively indolent biology, we consider surgery. Actually, we did a study of metastatectomy for pancreas cancer. The patients who benefited the most were people who had prior Whipple and then had Mets in the lung. Those could be resected and they did well. The ones with resection in the lung, in the liver, didn't do that well. But if it's an indolent history, relatively stable tumor, I would consider what you did, radiotherapy or local treatment. Now with ATM, I don't know. I didn't get the impression whether she's FGF, she is refractory to platinum or not.
So she responded very well originally. She had
Yeah.
a partial response.
Yeah.
And then we had to stop because of peripheral neuropathy and went on to FOLFIRI. And then the disease-free interval between September, 3 months only, when she started, the pancreatic mass started getting worse.
Right. So she sounds unfortunately like she may be refractory, because if they're irinotecan refractory, then there's cross resistance to PARP, cross resistance to cisplatin. You could try, cisplatin again, if to assess. But
so she actually went on to Gem-Nab-Pacli. Her liver disease just took off, progressed very aggressively. And we actually started her on olaparib, and she passed away a month after olaparib.
Yeah.
Now, my question is, when you see these reports,
Yeah.
they give this, niraparib, olaparib, and then they say FGFR1 amplification, they give these 4 or 5 drugs.
Right.
Now, the patient's son is trying to, import pemigatinib and,
Yeah. No, I won't do that.
So,
I won't do all
it's like,
that. This FGFR, it's a low amplification.
yeah.
Pemigatinib doesn't work that well. That other drug, daraxontinib, works better. But and in this case, I think this FGFR1 is probably a mechanism of resistance if it was done a little bit later in the course.
Mm-hmm.
So I don't think it would work. And if they are irinotecan refractory olaparib, that's why it didn't work. It's the diseases. Immunotherapy maybe, but honestly, we don't have anything at that point when they're refractory to chemo.
Yeah. So, so I think with the low level FGFR again, the point is, why I don't know why they put these companies.
It's misleading.
So misleading for patients.
Because amplification, you have to be at least 10x and higher. This equivocal amplification doesn't mean anything.
And it's for all companies, Indian, abroad, US. So I don't know how we stop it, because it's very misleading for patients.
Very
and
misleading.
Then
But you are in a good position. You have a tumor board, you discuss it out, that sort of thing. But even in US, people prescribe these ridiculous expensive drugs and they don't work.
Yeah. Dipanjan?
Yes, ma'am. So as far as the local therapy is concerned, we generally keep in metastatic cancer for patients who are symptomatic for that particular issues. Like sometimes we see that the pancreatic head cancer disease, there is increase in the localized disease causing pain or increasing jaundice, and IRE sometimes, if available, works pretty well. Dr. Naveen Kalra at PGI Chandigarh, he has done quite a bit of work on irreversible electroporation. And of course, SBRT is also, it is in fact more wider available. But in places where IRE is available, IRE has shown quite a good response as far as local palliation is concerned. That is one.
Yes.
If the patient is having ATM, maybe gemcitabine or cisplatin in a lower dose can be considered. I'm not sure. They have already received FOLFIRI.
He received Gem-Nab-Paclitaxel, and the liver disease just progressed through it.
Okay.
And I remember I treated her with a colleague in Ludhiana.
Yes. Third, I was just wondering, though it is G12D and not G12C, was any role of adagrasib?
No,
yeah,
that's G12C, no?
I know. I was just wondering.
Yeah, MEK inhibitor or something. Doesn't really work. Yeah.
I think there's some work that Shubham is doing on this space with hydroxychloroquine and MEK inhibitors.
Yeah, there's a trial actually through the
trial. Yes.
It's immuno plus hydroxychloroquine plus MEK inhibition. I think this is like hydroxychloroquine
now you can tell them 2 minutes.
or COVID. I kind of joke with them.
Yeah. Great. Dr. Ravi, you have not spoken, so maybe we'll have the last word from you. So we'll finish, Amey. I'm just going to ask Dr. Ravi whether he has any comments on the cases. Dr. Ravi Vatgaonkar, is he here? So no, if he's not here, I think we will close. If anyone has any last comments, I'm really grateful. Milind, you lit up the panel. So it was great to have your input, especially, with all these molecular, you have the most experience with this, and we are learning. Every week I learn.
We're all learning, and you're such a great group. This is such high quality presentation. So proud to be here. Yeah.
Thank you so much. Thank you. Thank you, everyone. I'm really grateful.
All right.
Thank you. And thank you, ISMPO, for putting such an amazing program together. Thank you.